Welcome to The Explainer. Trying to treat major depressive disorder can sometimes feel like you're navigating a really confusing, winding road with no map. So today, we're going to demystify that entire process. We're going to map out the clear, structured journey from the moment of diagnosis all the way to remission. All right, so here's our game plan for today. We'll kick things off by defining what major depression actually is. Then we'll get into the goals of treatment and the key phases of the recovery journey. After that, we'll dive into the treatment toolkit, see how the right fit is found, and finally, we'll talk about the path forward when the first approach needs a little adjusting. Okay, first things first, it's so important that we're all on the same page about what we're talking about when we say major depressive disorder, or MDD, because this is way more than just a passing mood. Right off the bat, this is a diagnosed medical condition. It is not just a feeling. A diagnosis comes after someone has at least one major depressive episode. That's a period of really intense, persistent symptoms. But here's the real key: its impact. It significantly gets in the way of a person's ability to function in their day-to-day life. And look, this isn't some small issue. The scale is just massive, and it's growing. Rates have been climbing for decades, and it's now a leading cause of disability across the globe. We're talking about a complex puzzle of biological, psychological, and social factors, all rolled into one. So, when someone actually starts treatment, what's the end game? What does a win even look like here? You might think the goal is pretty simple. Just feel less sad, right? But honestly, the target is so much broader and more ambitious than just lifting someone's mood. A truly successful outcome, it's really built on these four key pillars. The first one is remission, which means the complete disappearance of symptoms. The second is preventing a relapse, making sure those symptoms don't come creeping back. Third is all about restoring quality of life, getting back to work, to relationships, to feeling like yourself again. And of course, doing all of this while keeping things as safe as possible with the fewest side effects. Getting better, it's not like flipping a switch. It's a structured journey that unfolds over three really distinct and important phases. So this whole journey is actually mapped out on a pretty clear timeline. The first 6 to 12 weeks are what's called the acute phase, and the whole goal here is just to get those symptoms under control. Once that's achieved, we move into the continuation phase. That lasts about 4 to 9 months, and it's all about preventing a relapse. For some people, there might even be a longer maintenance phase of 1 to 3 years to stop future episodes from happening. All right, so what tools do we actually have in the toolkit here? Well, the options really fall into two main buckets: therapies that don't involve medication and, you guessed it, those that do. For what we'd call mild to moderate depression, the big guidelines from the American Psychiatric Association, or APA, and the UK's NICE both point to psychotherapy as a really powerful first step. NICE is a little more direct about it, suggesting meds only if therapy doesn't quite do the trick, while the APA sees them as more of an equal choice right from the start. But it's not just about talk therapy. There are some other really important non-drug options on the table. Things like electroconvulsive therapy, ECT, which is an incredibly effective tool for severe cases where you need a fast response. Then there's vagal nerve stimulation for depression that's been really stubborn, and other approaches like light therapy and even structured exercise can play a huge supporting role. Okay, now when we're talking about moderate to severe depression, that's when medications really step up as a first-line treatment. And this captures the single most important principle here. They all work about equally well. The real difference, and this is so important, is all about the side effects. And this table, it lays out that trade-off perfectly. You've got your SSRIs, which are often the go-to starting point because they're generally safe and pretty well tolerated. SNRIs are similar, but they can also help with certain kinds of pain. Then you have the older TCAs, super effective, but they come with more side effects and risks. And finally, you have what are called atypicals, like bupropion, which has a low risk of sexual side effects, or mirtazapine, which can help with sleep but might cause weight gain. See? Every choice is a balance. Okay, so you've got all these options, right? Each with its own pros and cons. How in the world how does a doctor and a patient figure out where to even start? It is definitely not a one-size-fits-all situation. Let's make this real. Let's think about a patient scenario, a pretty complex one, to see how this works in practice. So imagine a patient who's also dealing with a bunch of other medical issues at the same time.
You see, the decision is so personal. You have to weigh everything from what's worked for the patient or their family in the past to their other medical conditions, their specific symptoms, like are they dealing with insomnia or fatigue. And yeah, you absolutely have to consider the side effect profile, the cost, and just what the patient themselves is comfortable with.
All right, so let's go back to our patient for a second, the one with a history of bulimia. Based on what we just saw, one of those medications is a total non-starter. Bupropion is what we call contraindicated for people with eating disorders because it can actually increase the risk of seizures in that specific population. But look, the journey doesn't always hit a home run on the first try. And that's okay. It's actually really common for the plan to need some tweaks. The whole treatment process is designed to be flexible and adaptive. So if things aren't moving in the right direction after a good solid try, there's a really clear step-by-step playbook. First, you optimize the dose. Make sure the current medication has been given its best shot. If that's not enough, the next step is to switch to a different medication entirely. And a third option is to augment, which just means adding a second medication to boost the effectiveness of the first one. And here's what's absolutely crucial to get. None of this happens in a vacuum. Constant monitoring is what guides every single one of these adjustments. That means tracking side effects, checking in on how a person is actually functioning in their daily life, monitoring for any risks, and using standardized scales to get an objective measure of how things are going. So, to wrap all this up, what are the big things to remember? First, treating depression is a structured, logical process, not just a shot in the dark. Second, the goal is ambitious, full remission and getting life back on track. Third, the approach is super personalized. And maybe most importantly, there are many, many options. And there's a clear path forward, even if the first attempt isn't a perfect match. And that really leaves us with this one big, exciting question to think about. For decades, treatment has been based on this careful, educated process of trial and error. But as we learn more and more about genetics and the brain, are we right on the edge of a new era? An era where we can match the right treatment to the right person right from the very start? A future of truly precision medicine for the mind.